but I'm here. Alrighty. Hi. Why is this up down nose? Really? Hey guys, thank you for joining me. Tonight, I'm going to talk about why medical coders learn pathophysiology and medical billing, because sometimes when people are looking to get into programs, they're wondering why they have to learn medical billing. We're going to talk about that. And if you have any questions that are not really basic, like how to get started, where to get started, what I recommend, you can ask them. But for the basic questions, like where to get started, how to get started, you can watch my videos. I've got plenty, 1,500 videos. Trust me, I have covered everything. So I will be with you guys for the next 50 minutes because I have a meeting that starts at 8 o'clock. So I will only have a little bit of time with you guys, but just enough to hang out, say hello, and answer some questions. Now, if I can get my computer to cooperate. Come on. Okay, so we're not going to cooperate? No? Alrighty. Okay, you want to be stubborn? I'll pull it up over here. Didn't really want to. Come on. There we go. You see? That's all it wanted, right? I had to open up the other one in order for it to go. All right. Hi, April. Thank you for joining me. Okay. Sorry, guys. I'm trying to get this to come up this way so I can look at it and look at you guys at the same time. So tonight we're talking about why medical coders have to learn pathophysiology and medical billing. Pathophysiology is, of course, the study of disease. Now, the thing about it is when you're coming into this field and you have no experience in medical at all, or you have very limited experience, I don't want you to panic because this is something that will develop over time. No one will expect you to learn all of this stuff right away. What happens is as you go through your course and as you practice and you keep practicing, you will start to learn more about the disease process. Why is it important for medical coders to know about the disease process, aka the pathophysiology of disease? Why is that important? Because this tells you more about what the symptoms are, And a lot of times I'll hear from new coders, like, how would I know, like, what are the symptoms of this condition or that condition? Well, again, it all goes back to going back to that molecular level and studying pathophysiology. That's just a course that you have to take, or you can learn it from a book. It is not hard to learn from a book because you're just basically reading and then you're answering the questions. Or, as I always recommend when you are studying, is that when you're learning from books or you're trying to learn from books, you want to make sure that you are reading the questions first before you get into the chapter and start reading the text, because this way is setting that foundation of what are you looking for. Your brain is already going to be on alert, like, I need to pay attention to this, or maybe there's a word in one of the questions that will, okay, this looks familiar when you're reading it in the text, so you're able to retain that information a little bit better. Now, this will take time. This is not something that happens overnight. This is not something that you will get right away. But there are plenty of resources out there to help you. I do have the book that I recommend for pathophysiology in my other regularly uploaded videos, not in the live um, description boxes, because it's a lot of text to put in there. So if you watch any of my regular videos, you'll see I have all of those books listed. And it's as simple as you also looking in your public library to see what workbooks they have about pathophysiology. You can look online anywhere. They have book retailers online, and you'll see all the options they have there as well. There's nothing new about pathophysiology that if you got an older book or if you got a newer book, it wouldn't matter, okay? Because it's all the same. That doesn't change. There may be some more like things that they learn about, but for the most part, what you need to learn is going to be in any book, okay? And it's just those basic things. Like if you have, what is a good example? If the patient is a diabetic and their blood sugar is high, okay, one of the symptoms will be that they're sweaty, okay? Another symptom would be that they have to go to the bathroom frequently, okay, for lack of better words. So that's one of the things that you would notice, and you wouldn't pick up those symptoms unless it's related to something else different. But when you're seeing that the patient is coming in with, excessive sweating and excessive thirst, we know that there's something going on with that diabetes, because that is part of that disease process. When diabetes is high, the blood sugars are high, patient could be sweaty, they could have excessive thirst, they could have excessive trips to the bathroom. So it really all depends. But as long as a provider is documenting it and you can kind of connect those things, that's how you're going to be able to start using that pathophysiology knowledge when you're in medical coding. It is important because you'll see like the definitive diagnosis codes and you'll see the symptom codes, which will most often be R codes. The letter R, if you don't know yet, there's different chapters and they all begin with the letter for diagnosis coding. So when you have R codes, those are your symptom codes. When you have symptom codes, that means you got to be on high alert. Is anything here that we have definitive diagnosis wise, like diabetes is E11.9, right? Just off the top of my head, type 2 diabetes. That's not out of control diabetes, that's just your regular diabetes. But if you're reporting some of those symptom codes, you got to think, is this a part of that? And you could always fall back on what are the symptoms of whatever condition that you're trying to look up. So you can Google that, okay? Because most often you will have access to the internet when you're in the real world coding. Now for the exam purposes, you're not going to have that. You have to know. And trust me, there's roughly 2 minutes. If you have a CPC exam, you're getting 2 minutes, 40 seconds per question. With a HEMA, you're getting 2 minutes, 10 seconds, 2 minutes, 20 seconds per question. So you don't really have a whole lot of time just to think about those things, which is why practicing with your book is so essential, right? But as far as learning pathophysiology, that is why we have to learn it. Because the better you are at pathophysiology and knowing those symptoms and being able to have that critical thinking to connect those symptoms, the better off you'll be, because you won't be trying to pick up symptoms of a definitive diagnosis, okay? Because when we have a definitive diagnosis, we do not pick up symptoms. The only time that there's something related to that condition is if it is an injury, for example, and we're coding for a sequela. Obviously, if you have a fracture, you're going to have some pain. However, after you have healed and you continue to have pain, and after it's all said and done, the doctor says, well, this pain is related to this fracture, then we would report that pain because it is a sequela of that fracture. So if they have wrist pain and they said they fractured their wrist, 5 years ago, and it hurts, during like when it gets cold and things like that, and they say, okay, well, that's a part of, your old fracture, then you would code pain in the left wrist if it's the left wrist, pain in the left wrist, and then you would code the fracture code if that's what the doctor is connecting. But the doctor has, or the provider, not always a doctor, but the provider has to connect that pain to that injury. And if they do, that's when you can code for sequela. But those are the only instances where that can kind of happen, right? So those are where you can do those kinds of things. But it is just a matter of practice, practice, practice. Hi, Priscilla. Thank you for the green and blue hearts. Hi, Dee. Nice to see you. All right. So, but yes, that is why we learn pathophysiology. It is not as scary, honestly, as you might think, because like, oh my gosh, why do I have to learn this? And it really kind of, when I was learning pathophysiology and I had to learn like about all these things like the mitochondria and all that other good stuff, when I had to learn like down to that level, yes, it did get a little bit nerve-wracking, but you get used to it. But a lot of it is just drawing out pictures, because that can kind of help you too. And knowing some of these terms will help you, especially if you work in the lab, as well. So those are things that you never know where you're going to start at. And so for some people, it's easier for them to get hired in the lab as their first job. And they see a lot of like the same procedure codes and things like that, but you're still getting that exposure. And so those are things that kind of help when you are learning pathophysiology and you get out in the real world. And it's connected by the specialty that you're in, for example, the lab. So that is why we learn pathophysiology. Why do we learn medical billing? I get the message all the time from people, I don't want to be a medical biller. I got into coding because I want to be a medical coder. Well, or I wanted to be a medical coder, but they're pushing me into billing. No one pushes anybody into billing. You go into billing by your own choice. Sometimes when you're trying to find your first job in coding, a lot of people will get discouraged because they see everybody wants experience, and how am I supposed to get experience if no one will hire me? They will hire you. They will hire you based on your knowledge, because if you are in an area that has lots of coders who have experience, and then all of a sudden, they need coders, they're going to call the people, of course, last, who have no experience, but they're going to see what you know. And if you're showing up there knowledgeable already, or having a good base, which is knowing your pathophysiology, knowing medical terminology, knowing medical billing, these things are very helpful, because they may not have you billing. They may have you just in coding. I have been a medical coder for 17 years. I have never once, one day of my career, been a biller. Do I know medical billing? Yes, there's a lot of things that I know about billing. There's a lot of things that I still need to learn, but I know enough to get around. Why? Because there's some things about billing that is helpful for coders to know. As coders, we have to sequence procedures by the highest, the most expensive procedure first, and so on and so forth. Because we learn in medical coding school, or we learn in independent study, that when you do this, that the insurance is going to pay 100% of the first procedure. They're going to pay a percentage of the second procedure if there's not some caveat on that second procedure. So those are things that we learn, and because we know about billing, even though we're not doing any of the billing processing, we still understand that sequencing the procedures by payment amount is important. Blue, how do we know how much the payment is? Well, when you're working with an encoder, they will put a price. That may not be the price that they get, but they will give you like the general price of that procedure code. So that's how you learn to sequence, okay? And you as the coder are sequencing these correctly. When it goes off to the biller is usually the one that is making sure that these are sequenced in the correct order, because there are some places where the coder says, that's not my issue. I'm not a biller, so I don't care what sequence these go in. And you would be wrong, because you can still get denials based on incorrect sequencing. So while the coding may be correct, if the sequencing is not correct, the claim can get denied. Or it could get paid out, and when it gets paid out, guess what happens? There's less money coming in because you sequenced it incorrectly. And the biller didn't think to, hey, we got to sequence this correctly. So this is why I tell new people that want to, oh, I want to be a biller so I can make all this money. Okay, if you have no experience in billing, you have no business doing that right out of the gate. I don't care who says what, okay? When it comes to, like, when you're out there and you're billing, you need to have experience in coding. You need to have experience in billing already to be on your own. And this is just to protect you. It's to protect the provider, and it's to protect that practice. Because again, if you are submitting bills that are incorrect, guess who they're going to come looking at? Not the coder. If there's no coder, they're going to come looking at that biller. You are the one who submitted these. So you're the one who's saying that it's correct. So again, this is why billing is so important to coders, because we have to work together as a team. I always say billers and coders are cousins. We're cousins because we don't do the same things. We do two different things. And when I have a provider that says, oh, this is the biller. No, I don't do billing. I do the coding. And I just make sure that all of the codes are appropriately selected and they're linked to the appropriate procedures. That's what I do. So I don't do anything with billing, but I do understand the fundamentals of billing. And that's very important. So when we think about DRGs and MSDRGs for my inpatient coders, that's why, we think of APCs and all these other things on the outpatient side. These things are very critical for coders to understand, because while those are considered billing things, we still need to understand how important that is. Because if you put a patient in the wrong DRG or MSDRG, you put them in the wrong category, that facility loses money. It is literally, to put it very simply and to cut out a lot of explanation, it is literally the difference between getting a $10,000 payment and a $100,000 payment for the facility. So that's why, again, we have to learn this. And just because you learn billing does not mean that you have to be a biller. On all 4 of the main medical coding certifications that are out there, the CCS, the gold standard of medical coding credentials, the CCA, the CCSP, all these are with the American Health Information Management Association, or if you get the CPC with the American Academy of Professional Coders, each one of these exams, each tests us on reimbursement. So you will have to learn the basic things, whether it is outpatient or inpatient or just outpatient. So you do have to learn about those. And so that is why that is important. And just because you learn it does not mean you have to do it. It is just part of it. And if you're going through a formal program, sometimes they'll have you practice on filling out the forms for billing so that way you can get that sort of feel for it. And sometimes they do this because they don't know where you're going to land either when you get out in the real world. So it's important that you know these things. Even though that's not your job, it's critical that you learn this. I would never say, well, that's not my job, and purposefully not learn it. That's stupid. That is really stupid. And with some of these procedures, with some of the insurances, and it depends on the insurance, there's a cap on how many units of that procedure can be reported, like the allergy testing. Some of these people who come in for allergy testings, the doctor may do 100 scratches for the scratch test, right? So they put a little bit of whatever allergen they're trying to identify the patient is allergic to. And if they do 100 scratches, for example, some insurances will only pay for up to 80. So basically you're doing 20 more for no reason. And so again, if you as a coder know this is a billing thing, but this is where you could educate your providers. Hey, you're doing 100 of these, but 80 of these are this is the cap for this insurance. And not that they have to switch or anything like that, but they do need to understand that, they can't get upset if they see, oh, well, why didn't you bill for all these other, tests that I did? Well, this is why. So it's just letting them know, so that way that they can be aware and they can decide for themselves, because they need to see like what is relevant for this patient rather than just doing anything and not really thinking about which test are they running, right? So it's just my advice anyway, but that's why we learn billing. And it's not so that, oh yeah, you can do this if you can get more money with this and you can get more. No, no, no. Coders never code based on money, as far as like, hey, this procedure is more expensive. No, we code based on the documentation, based on what the provider has there, and we can educate them as far as like if there are elements and details that are missing, we can educate them on that, because that will make it more specific. Because in some of these procedures, there's open procedures, there's laparoscopic procedures. It's very important so that we code the correct procedure. Which approach is it? Okay, and it's the same thing if they have lacerations. How many layers is this? And giving those providers that education is also critical, because they may say, oh yes, this was really complex, but if you're not telling us how deep those layers were, how do we know? And again, it goes right back to pathophysiology, because if you don't know to ask these questions because you don't really understand, that's where things can get messed up. Or the coding is not as specific as it could be, or it's not as sophisticated as it could be. Because as you go through your career, you will see that your coding gets more sophisticated, especially if you're putting forth the effort to learn like you should. This is my advice anyway. DRG is a diagnosis related group. So when you are going and staying in the hospital, what they do, this is the simplest way that I can explain this without having to go into a really long episode and I lose people, right? So when a patient comes in to the hospital, there are some patients that this is going to be a very simple, straightforward inpatient stay, maybe for a couple of days, okay? And the DRGs that are classified to that type of condition that they would be admitted for, they are only going, the insurance is saying, okay, if you are in this DRG group and the patient is like, this is the hospital is saying, hey, this patient is in this DRG group. That means that this patient has a very simple, straightforward thing that they had to be admitted for. So the insurance is going to say, patient in this DRG is going to get a 3-day stay in the hospital. And we're only going to pay you X amount of dollars. Let's just say $10,000. We're going to pay you $10,000 and the patient gets 3 days to stay in the hospital, because this isn't a serious condition, but it was serious enough that they had to be admitted. And so while the patient's in the hospital says, okay, well, we can patch this patient up really quick and they're going to heal. They're going to be just fine. But we were admitting them for whatever reason they were admitting them. And then they end up saying, okay, well, rather than staying here for 3 days, we can get this patient out in 2 days, because, we were able to take care of them well. And so they say, okay, well, the hospital is getting that, for example, $10,000, right, for 3 days, which comes out to $3,333 a day, roughly. But if they are able to get this patient out in 2 days rather than 3 days, well, they just saved themselves from having to spend another day of care for that patient. And they don't have to feed that patient for that day. That bed is not being used by that patient. It can be turned over and used for another patient. Meanwhile, we still get $10,000 for taking care of a patient who was in and out in 2 days rather than 3 days. So we saved the facility money based on that. That is the whole kind of thing behind DRGs. If a patient is coming in and they had a major accident, and the DRG weight, because they're all weighted, so some are weighted lighter than others. The more heavier weighted DRGs, patient comes in, they were in a multi-trauma accident. They have several broken bones. They have lots of things going on with them, lots of complications, a punctured lung, all kinds of stuff, internal organs, got all messed up and things like that. So this heavily weighted DRG group, because this patient is going to be using more resources from the hospital, more specialists, they're going to stay in the hospital longer. So the insurance is going to say, okay, for this patient, you're going to get 30 days for this patient to stay in this hospital because they have all of these conditions based on this DRG weight. And the hospital is able to say, okay, we can get this patient out in 25 days. Patient is rehabilitated, they're right on top of that patient, the patient's doing well. Well, let's just say they got a $200,000 payment for that patient. They just saved themselves a whole week. Now, instead of the patient being there for 30 days, they're out in 25 days, right? And that hospital is able to turn around that bed and that another patient can get in there. So it's based on the resources used, diagnosis related group. The more sicker those patients are, they're going to be in a higher DRG weighted group, which means they're going to get more money for the facility. Now, you're not going to be admitting patients willy-nilly because some insurances will not cover, because this patient doesn't have anybody to take care of them. That's not the insurance's problem. So the insurance is not going to cover that. So it would be the patient. So there's things that happen. Why the appropriate DRG assignment is so critical is because facilities can lose money based on that. But this is for the inpatient side of the house. So if you are working in the outpatient clinic and you see patients, the doctor sees a patient, they have their little visit and then they take off, that has nothing to do with DRG. DRG is only when they're staying in-house and they're staying under the watchful care of these doctors and these nurses and all these people that are taking care of them. That's when DRG applies. But it is a way of telling the insurance company this patient is really sick and they're going to be using a lot of our resources. So this is the weight we are giving to this patient. And that's how they sort out that payment. But if a patient is supposed to be in and out and something else is going on and the appropriate DRG assignment is not made and the patient stays in there for a whole week, well, the facility ends up eating that cost. Instead of 3 days, they're there for 7 days. That facility eats those 4 days of cost to take care of that patient because the DRG wasn't assigned appropriately. The provider may not have documented well. There's a myriad of reasons why something like that would happen, but that's how facilities lose money. And they also lose money because people that are in there don't know. And for those of you that want to get fresh and talk about AI, AI learns. Somebody told me with their whole chest this. No, you're wrong. AI learns every time you use it. Okay, so AI, you said it yourself. AI learns every time you use it. So if a person is ignorant to these coding rules and they're just going by, because I don't know, no one trained me, that's what the AI is learning. Why? Because as I said in the video, it can't critical think. Just before, like how you said that whole statement of, no, you're wrong. Really? AI only knows the way that it's programmed to be. And if it's doing any learning, it's learning based on who's ever training it. And if that person doesn't understand the coding and doesn't understand what they're doing, that's exactly what it's learning. And so it perpetuates the problem. So I'm just saying, before you come at me thinking that you're so smart, think again. And as I've always said, and I will continue to say, AI does not have the ability to critical think. Because it does not have the ability to critical think, this means that we as coders will have work because we can still critical think as long as we insist on keeping our critical thinking. This is why I tell y'all about TikTok, because when you are exposing your brain to these little short clips, these 10-second, 15-second clips, your brain is not having time to have a beginning, a middle, and an end. All it is doing is just, it's got the meat of the potato every 10 seconds, 15 seconds. So you're getting that hit of dopamine. How many of these little clips are you going through in an hour? So The more you do that, the more your brain is being trained. Hey, we're getting to the meat of the potato. There's no patience anymore for a beginning, a middle, and an end. So that's why I will always keep my content long. I still get people who say, well, you need to shorten your content. No, I don't. No, the heck I don't. Because the more that I try to shorten it, people have even more questions. So you will sit here and listen to me so that I can explain to you, because your brain needs it. And that's how we keep our attention spans. People who are into the TikTok and they're doing that all the time, shortened attention span. I've had many people reach out to me and say, Blue, I didn't know what you were talking about, and then I understood, because you need to have a long attention span. And attention spans are getting shorter and shorter because people are just as rapid with the information. So just make sure that you understand AI is only as smart as the person that is programming it. And these people that are programming these AI things for medical and health information and medical coding, they are not medical coders, period. They are some software developer. What do you know about my industry? No. You could sit down. sit. Would you say DRG is like a payment? It is. Who is responsible for assigning the patient to the appropriate DRG? That would be the coder. So, hi Marcos. Yes. So, but yeah, that's what that is. When you are doing any kind of assigning and stuff like that, that's on the coder. And some places it will be the coder / the biller, because sometimes people don't understand that we are two different functions and not just one. And yes, while a coder can do billing, depending on the size of the practice, some like private providers that are just working by themselves, they'll hire a coder biller because it's just them, and one person can handle the whole thing. But in the bigger practices you get into, you will have like more. You need to separate those tasks better, so that way the biller can focus on the billing and the coder can focus on the coding. Because if you have a coder trying to focus on billing, if you end up getting a denial, that coder has to be able to look at that denial reason, and sometimes they won't even tell you why. You have to look and see like what happened here. You have to be able to explain yourself why it is wrong, or why it is right, rather why it is right, so that way you can get your money back, or you can fight for the provider to get their money, or the facility, depending, where the denial is going to, provider or facility. And so that takes time. Meanwhile, if you are a coder / biller, your coding is getting behind. And if you don't get these claims processed in time, because there is a thing as timely filing, okay? And you don't want to get behind on filing those claims, because if you do, that's penalties. And if you have penalties, there's less incentive awards for these facilities and providers for timely filing. So there's a lot, y'all, that goes into that. But yes, that is Priscilla. That is who is responsible for assigning the patient the appropriate DRG. So yes, and you can find lots of tools. There's lots of tools in coders when people are coding, and it will tell them, what is what. So it's on the coder to know how to assign and what is appropriate. So that way they're able to do that. But yeah, so that's why you have to learn about billing. And it's not the funnest thing sometimes, especially because a lot of insurances think it's a fun game to change the rules frequently and without warning. So that's another thing too that you have to watch out for. But if you are coding and you are coding consistently, and you know the rules and you can follow the rules and you're paying attention to that stuff, it gets to be a little bit easier. And then you can focus on, what is important, whether it is educating your providers or making sure that, all the documentation is appropriate. Okay. Because while a lot of us are not nurses, a lot of us are not trained medical professionals, we can still, after a while, spot where there are holes in the documentation. For example, myself, when with my providers, I noticed that a lot of them in the beginning when we switched over to ICD-10, they weren't putting external cause codes. And to me, that is very important because the way that I look at it is these records are legal documents. All medical record documentation is a legal document, meaning that this document can be called in front of a judge at any time. So if a person is injured, it is important to know why this person was injured or how they were injured. So if they were in a car accident, this may be tied up in litigation for an injury claim. Okay, so that's why it's important that the provider documents every single time they have a wrist fracture because they were in a car accident on this date. Okay, if I can get a little bit more detail, that's great. It was a pickup truck, they were in a collision, the person was a driver. That's perfect because I can get a code based on that. And they have to be consistent with that. And that's a hole in the documentation because how did this injury happen? And while not all states have a state requirement to report external causes, it doesn't mean that you shouldn't do it. So there's that saying, what is it? Just because you can doesn't mean you should. And so what I mean is well, it doesn't say you don't have to, but it doesn't mean that you should, because you never know when the tables are going to turn and things are going to change. Okay. So I would rather my providers get used to that now rather than later on. The other hole that I found was they would say, oh, the patient is post-op 6 weeks. What's the date, sir? Well, it says 6 weeks. Okay. But if what happens if you're using copy forward, which you shouldn't be, what happens then? How do we know? Or how do we know that this is specifically about that particular condition? So I have to put in the date of surgery every time? Yes, because I am not allowed to go back and look at previous documents to find out when this surgery was. Oh, it turns out it was 8 weeks ago. You see, that could be a problem, right? Because even though you're in a 90-day global period and you are 8 weeks out of surgery, what if it was 12 weeks and you were right at that cusp and it turns out it was 14 weeks ago that patient had surgery? Well, guess what? You're out of the global period. But me, following your documentation, you said 12 weeks without a date, and I took you on your word. Well, guess what? I would have given you a 99024, which means that you would have gotten no credit when you're out of the global period and you were eligible for credit. Oh, that's why those dates are important, because they don't need to think. Because let's just take that off the table. I don't want them to have to sit there and look at, oh, the calendar and count how many weeks it is. I need you to give me a date so that way I know, and it's without a doubt that is what it is. Because people get dates confused all the time as far as like weeks and stuff like that. They could say, oh yeah, it was 3 weeks ago. Oh no, wait a minute, not 3 weeks, it was 4 weeks. Okay, so then why are you having to stretch your brain? Just give me the date of the procedure and I can calculate that myself. Because again, that's where it's going to be the difference between getting a 99024, which that means you're still in the global period, or getting an evaluation and management level if you're out of the global period and this is just a follow-up. So knowing these things is very important, and it goes back to billing. Because if you are billing and you are okay, cool, this patient is 14 weeks out of surgery. Well, technically, it's if they're saying that this is a post-op visit, hello, it would have only been 12 weeks, not 14. Yes, they would have had surgery and they're doing whatever, and sometimes they're continuing on with like physical therapy or something. But at least we know, can this qualify for evaluation and management, or is it going to be 99024? Which one is it? Okay. And it's on the coder. It's on the biller to understand these things. And I always say to billers, I know some billers and they say, well, I know enough to get around. If you don't know about coding, that's the difference between a provider and a hospital getting paid appropriately versus not. And just because that's not your job doesn't mean that you need to be that way. I would never say, well, I don't do billing, so I'm not going to worry about that. No, I know about these things because I make it my business to know these things. I'm not a CDI on paper, but I make it my business to understand what a CDI does so that way I can educate my providers. CDI is clinical documentation integrity, making sure that you fill in the holes like the data surgery and like, the cause of the injury. These things are important, because if the provider's not filling in these things, credit can get missed, money gets left on the table. And again, while we don't do things based on money, we are to make sure that the provider is getting paid for their work, whether it is their physical work doing the procedure or their cognitive work deciding, what level to give them based on their documentation for evaluation and management of that patient. So, yes. All right. I got about another 6 minutes because I need to leave a little bit before before 8 o'clock. Does anybody have any questions? Does that help to answer those questions of why coders have to know about billing and why they have to know about pathophysiology? I hope so. And I will have a show uploaded for tomorrow, and that's going to be about why you should or should not get a degree in health information technology or in health information management. The thing about people who get degrees, I had somebody in the audience a couple nights ago that talked about what kind of job can they get with a degree. And the degrees, health information technology, which is the associate's degree in health information technology, or if you have a bachelor's degree in health information management, these are for our leaders. So if you are not interested in leadership, if you are not interested in being a lead medical coder, if you're not interested in being an educator, you should not be getting these degrees. Now, the people from the school, like the recruiters from the school, the colleges and stuff, they'll tell you, oh yeah, you need this degree and this is the fastest growing market. And, but they're not telling you that it's for leadership. They're saying, oh, well, yeah, you can be a coder. Somebody with an RHIA, which is a person who has passed that designation because they have a bachelor's of science in health information management, or they have a bachelor's of science in health informatics and information management. That person who has an RHIA and goes out there just to do coding is technically working under their potential. Some people take offense to that when I say that. But here's the thing. If you look at the syllabus for any of these programs, health information technology, health information management, if you're looking at those, it's telling you that what is covered in this program. The data analytics is covered, medical law and ethics is covered, managing people, forecasting is also included in that. So these types of things are specific to our leaders, not to coders. And the coding, especially in the health information management programs, it is almost an afterthought. It is not in depth. It is really more of an introduction to, hey, these are the codes, this is what this is. It's just getting you just a regular foundation of knowledge in coding and, doing all that stuff with billing, but it is not giving you details. It's not giving you that in-depth, advanced understanding like some people think it does. And, well, no, I want to get a degree because, I want to make sure that I know everything. If you're never going to use that degree, you just wasted money. And that money is anywhere between $20,000 to $50,000 that you just wasted. And I don't know why some people insist on getting a student loan. I would never get a student loan, never. Because to me, it's just like, no, there's many ways to pay for a degree. And there's a lot of colleges out there that offer reasonable tuition rates and all that good stuff if you really have your heart set on getting a degree. But if you are just getting in and your whole big old thing is to be a coder, you should wait to get a degree. Only get a degree if, especially in RHIT, okay? If you want to be a lead medical coder, which you need to have experience for that, you need to have some coding knowledge for that, a lot of coding knowledge for that. But don't just have the degree. You have to have a coding background in that already established, okay? And then there is, you know, the RHIA. Again, you're working under your potential. And I always get people who are offended by that. You can get offended all you want to. And I wish you'd found me before you decided to spend all that money and all that time to get a degree, that you could have gotten a certification and made way more. I'm just saying. You're welcome, Priscilla. Hi, Tirza. I know you're on my Patreon channel. So I post those all the time, and I have in the past. I haven't done Patho specifically in the last couple months, but you can search through what I've posted for Patho, and you'll see those exercises there. There's a lot of books that I recommend, and you can even look in the description box of the other, not the lives, but the regular videos, when I talk about like the resources, like free resources that are out there for medical coding and learning. I list the books. Okay, and it's just as simple as looking at those. Rose says, what about the health information management degree? As I said, the health information management degree is only if you want to be in leadership, like you want to head up a department, but you need to know about coding in order to do that effectively. You cannot be in leadership in health. This is what I've learned. In health, I've been a coder for 17 years, okay? Just so y'all know. If you do not know about coding and you go and get yourself an HIM degree, right? Health information management degree, and you don't know a lick about coding, but hey, I can steer the ship. I can manage a whole department. But you don't know what's going on with these codes. So then when people come to you and ask you, hey, why is this like this? Or I don't understand why the coders are getting upset with each other because of this disagreement or whatever. If you don't know anything about that, you need to step aside and let somebody else do that. Because again, somebody with that level of education needs to have coding background. Don't just get into the health information management program and thinking that you're going to coast into a leadership position and not know about coding. You've got to know about the coding. I wish people would understand that is what that is for. It is for leadership. If you do get an RHIA and you end up being a coder, you are working under the potential of an HIM degree, because the HIM degree should be in the C-suite over there with all the rest of the C-suite people in that hospital or in that facility or in a nursing home, because they also work in nursing homes as well. They direct nursing homes. And I think that there's a certification for nursing home direction, but I know that somebody with an HIM degree can do that as well. So it is about knowing that. And they also, people who have HIM degrees can also work in the prison system as well. So just so we all know. You're always so helpful and informative. Thank you. Good. All right, guys, I got to get out of here because I got a meeting in 3 minutes. So thank you guys so much. And I will post that video tomorrow talking about the degrees and why you should or should not get them and what kind of positions you can do with those. I will see y'all next time. Bye.